Welcome to the debate. Our focus today is on two highly contrasting ways of looking at risk in body modification, specifically with nose rings. The central question we're facing is this: does the objective clinical data on physical trauma give us the most reliable, actionable understanding? Or, does the sociological and psychological theory offer a more comprehensive framework? I'll be arguing for the primacy of the objective clinical protocols.
And I'm going to come at this from a different angle. I'll argue that the real explanatory power rests with the psychological and behavioral theories. They get at the etiology, the reasons why the risk keeps showing up, which is a depth that, frankly, a clinical checklist just can't provide.
Well, the most reliable knowledge comes from clinical necessity. The material lays out these uncompromising safety protocols for trauma that are, they're universally applicable. Take bleeding, for instance. Initial hemostasis needs firm, continuous manual compression of the cartilage for a non-negotiable 10 to 15 minutes. If that doesn't work, you have to move right to vasoconstrictive agents like oxymetazoline, Afrin. And even more critically, there are immediate checks for a septal hematoma. That's a collection of blood that can kill the cartilage, and if you don't drain it, it leads directly to necrosis. This is objective, it's time critical, and it's universal.
Okay, I see that. I do. But I'd frame it a bit differently. The clinical data treats the injury, yes, but the psychological data can identify the vulnerability that leads to that injury in the first place, or even to repeated injury. The source material highlights studies linking people with body mods to significantly higher scores in things like sensation-seeking and general risk-taking. And some studies even show a notable prevalence linking multiple modifications to profiles like borderline personality disorder, or BPD, and even histories of childhood trauma. This framework, while it's complex, it helps us profile for other clinical risks, like, say, noncompliance with wound care, which the trauma checklist alone can't predict.
I respect the depth of that, I do. But look, respectful debate gets us to the truth. And the truth here has to be prioritized by immediate safety. The clinical data on wound care, applying antibiotic ointment, for example, or advanced techniques using silver nitrate sticks for cautery, those are immediate practical steps. They save tissue, they might even save lives. A psychological profile just doesn't intervene in that moment of crisis.
That's a compelling argument, but have you considered that the theory suggests trauma can become someone's entire personality? Doesn't the very need for these repeated urgent interventions point directly back to the behavioral risk factors that put the person in that chair to begin with? I mean, the material observes that the common denominator in a string of failed relationships is often the highly modified person. That suggests the psychological profile, the assertiveness, the predisposition to chaos, is the primary driver. The physical trauma then becomes just a secondary and, frankly, a predictable consequence.
I'm just not convinced by that line of reasoning. We have to be so careful not to generalize causation from correlation. The material itself even cautions against it. The clinical definition of something like epistaxis, a severe nosebleed, and its management is universal for every patient, regardless of their history. When we lean too heavily on these broad correlations, we risk misinterpreting a predisposition as some kind of inevitability. And that's a huge limitation in acute medical decisions.
I understand the caution. I do. But the statistical difference in traits like extroversion is academically robust. It's significant. The correlations with trauma histories are just too common to be dismissed entirely. And look, the practical element is even acknowledged in the physical protocol. The section on jewelry management says to remove it to prevent it from acting as a foreign body. So we are literally treating an intentional alteration that, according to the data, may itself embody an underlying behavioral risk that has to be addressed.
Ultimately, the material provides clear, objective, and life safety critical information. Things like the urgent drainage of a septal hematoma, the specific pressure times. This evidence-based approach to the immediate physical reality, it remains the most necessary and reliable knowledge we can get from these sources.
But the material also shows that complexity requires more than one perspective. While clinical management is absolutely crucial for safety, for the how-to, the behavioral correlations offer a really powerful insight into why those risks show up in the first place, and maybe how we can tailor long-term care for a better prognosis.
Both the necessity of clinical protocols and the statistical presence of these psychological patterns emerge from rigorous challenge. And they both offer different yet clearly essential perspectives on this material.